Hi, I'm Dr. Gregory Piazza. On behalf of CME Outfitters, welcome to Real World Data for Real World Patients, a broadened lens to inform decision-making in venous thromboembolism. This series of activities is brought to you by CME Outfitters, an award-winning, accredited provider of continuing education for clinicians worldwide. In this first episode of our BriefCase series, entitled Cutting Through Comorbidities, Clearing the Way to Appropriate Anticoagulant Therapy in Patients at Risk for DVT and PE, we're going to explore some of the challenges in providing antithrombotic therapy for our patients with VTE. Again, I'm Dr. Gregory Piazza. I'm the Director of Vascular Medicine at Brigham and Women's Hospital and an Associate Professor of Medicine in the Cardiovascular Division at Brigham and Women's Hospital and Harvard Medical School. And I'm really excited actually to be joined today by Dr. Jeffrey Barnes, who's an Assistant Professor of Cardiovascular Medicine and Vascular Medicine in the Department of Internal Medicine in the Division of Cardiovascular Medicine at the University of Michigan Health System in Ann Arbor. Welcome, Jeff. Really nice to have you with us.
Hey, thanks, Greg. I'm really excited to be here.
Excellent. And also joining us today to provide some additional clinical perspective and to keep us in line and to demonstrate primary care physicians and cardiologists and the collaboration that we often have on VTE patients is Dr. Margot Savoy. Dr. Savoy's chair and associate professor in the Department of Family and Community Medicine at the Lewis Katz School of Medicine at Temple University in Philadelphia. Welcome, Margot. Great to have you.
Thank you. It's my pleasure to be here.
Awesome. So let's start by reviewing our two learning objectives for today's session. First, after participating in today's activity, clinicians should be able to assess common comorbidities in patients requiring anticoagulants. And then second, clinicians should be able to apply anticoagulant strategies to the care of patients that reflect randomized controlled trial data, as well as real-world data, and also incorporating the individual patient characteristics and preferences. So with those two learning objectives in mind, let's first talk a little bit about what we're worried about in this session, which is VTE. It's become a major US healthcare imperative. And the reason it's so important is because it's actually quite common. So VTE for us comprises deep vein thrombosis and pulmonary embolism. And it affects up to 900,000 individuals in the US each year. And it leads to nearly 100,000 annual VTE-related deaths. So it's a major problem, it's common, and it's life-threatening. What's worse is it's actually preventable. It's the most preventable cause of death in hospitalized patients. The incidence is likely to continue to increase because the population's getting older and patients are living longer with chronic medical conditions such as obesity, heart failure, chronic lung disease, cancer. And so it's really important that we know about VTE and we keep it sort of on the top of our list when we're seeing patients, because if we don't, then we have the risk of missing it. We're really lucky to be able to share a case of a complex patient presenting to us with different issues that complicate the management of VTE. And to talk to us about this case is going to be Dr. Savoy.
Hi, Greg. It's Margot. I saw a patient that's been sitting heavy on my mind, and I debated calling Jeff or you, but you on the phone call. Do you have a moment to talk to me about it a bit?
Absolutely. And it's so funny that you actually said you were going to call Jeff too. We were Zooming online right now talking about a project that we're doing. So you're actually going to get 2 for 1, which I think, when this stuff happens, it's excellent. So hit us with it. Give us both a chance to talk about this case.
Awesome. So I guess I hit the jackpot today. So I get you both. So thank you both. So earlier today, I was doing visits and I saw a patient, Walter, who's African-American male. He's 71. He actually came in to see me because he was having pain and swelling in his right leg. In general, he does pretty well. I mean, he does a good job taking his medications. He's got high cholesterol. He's got hypertension. He's got diabetes type 2. He did have a surgery for carpal tunnel about 20 years ago, but he hasn't had surgery in a while. So he'd come in because he was having this pain and swelling. We sort of talked through and I just confirmed some of his social stuff. So he does still drink about 2 glasses of wine each night. He smokes about a pack of cigarettes a day. Back when he was in his 20s or 30s, but thank the Lord we worked through that. So he's not doing that anymore. But he does still have a sedentary job. So he works as an accountant. So he kind of spends a lot of time sitting still. So in the visit, we did an exam, like his height's still about the same. He's 5'10", he weighs about 225. By my math, it's around about a BMI of 32. He didn't have a fever. His heart rate was fine. His blood pressure was actually pretty decent. He was 134/84. His lungs sounded clear. His oxygen sat was fine. So honestly, like his exam really wasn't that exciting except for the swelling in his leg. And it was really just the one side as opposed to both. So at first I thought it was maybe just, him sitting all day, but then after I sent him home, I got a little bit nervous. So he does take a bunch of meds already. So he gets a little bit, stressed if I have to add something else. So he's on a statin. He's on 2 high blood pressure meds. So he takes both valsartan and hydrochlorothiazide. But for the diabetes, he's got metformin. And then I finally got him switched over to doing the injection with the insulin for the diabetes also, because we had some trouble with the insulin. And so I know he's going to push back if I have to start him on a med, but I'm a little bit worried. And so I just wasn't really sure what you guys might think about his case, or did I do the right thing, just sort of not doing anything, or maybe I should have tested him. I'm not sure.
Yeah, I mean, I'm glad to have Jeff with me because I think tackling these patients is so challenging. It's nice to have a second brain working on these things. I think, before we talk about the case, sort of in its totality. It's probably worth giving a question to our audience, which is, which one of the following factors increases Walter's risk for VTE? So we learned that he has daily alcohol consumption. Your math shows us that his BMI is increased and that he's in the obese range. He's got this surgical history, but that sounds like maybe it was remote. And then maybe he has a factor V Leiden mutation. It's hard to know. So what do you think? Or maybe we just, it's very hard to pick apart his risk factors, but let's give the audience a chance to think about the possibilities here. And so hopefully the audience had a chance to really think about the different risk factors that are here for this patient. For me, I think the obesity is what stands out as a major predictor of developing VTE. What do you think, Jeff?
Yeah, Greg, I think you're probably right. It's probably one of the most common yet underappreciated risk factors for developing venous thromboembolism. Obesity is clearly an epidemic in America, and we see a lot of patients like this. I think about a number of things that we often talk about as being risk factors for VTE. Things that are commonly mentioned are surgeries. We talk a lot about having a blood clot after a surgery. We talk about people who are hospitalized and getting a blood clot either during or after their hospital visit. There are other medical conditions that can weigh in. Some people will have a thrombophilia. You mentioned factor V Leiden there. Of course, that tends to be something that's much more common in Caucasian patients than African-American patients. And so that certainly goes down a little bit for me. But even other, rarer things like heparin-induced thrombocytopenia or the more rare thrombophilias, those are things that I think people talk about. The other one that I think we always have to consider, especially in our older patients, is not just their older age, but certainly cancer. And that's something I always consider too, is could this patient have either a cancer we know about or something we don't know about it, and that contributes. So, Margot, when you mentioned this patient, I was thinking through the different things. He's an older gentleman. He's definitely obese. We actually know that African-American patients are at higher risk for developing DVT and PE than Caucasian patients. And just his comorbidities kind of set him up for this. So I'm not at all surprised that he may be at risk for developing a blood clot. That wouldn't shock me at all.
And I had a quick question, Margot. How is he with his age-appropriate cancer screening? As Jeff was talking about the risk of cancer, prostate cancer being somewhat more prevalent in African Americans, has he been able to keep up with you and all of his cancer screening?
I mean, fortunately for us, yeah, like he does a really good job of staying on top of all his preventative care. And so he's all good to go. And he doesn't have a family history of any prostate cancer either.
I think another question that sort of came up with Jeff was talking about surgery being recent. Jeff, how recent does surgery have to be? I mean, he had carpal tunnel surgery 20 years ago. Is that going to count for him?
Yeah, I get this question a lot, right? How closely associated do these things need to be? And for me, I'm really looking for a surgery or, somebody having a cast within about 4 to 6 weeks. So for this gentleman, we're talking 20 years. That's not at all connected. I'm looking for something that's much closer in time.
Okay. And then alcohol consumption, is that a risk factor that we should be asking about?
I think of alcohol consumption as being something that concerns me about bleeding risk, especially if somebody's drinking quite a bit. They may have liver dysfunction or maybe at risk for falls, things like that. But it sounded to me like he was just having 1 or 2 drinks in an evening, and I don't think that really poses much of a risk for clotting or bleeding, at least from the way you described it, Margot.
All right, well, let's get back to our case discussion. I think that there are a lot of different issues to unpack here, especially in the evaluation and considering what sort of therapies we might institute. Safe to say, Margot, that he got diagnosed with deep vein thrombosis. Is that right?
Yeah, and so after the fact, I got really worried about it. So I sent him to get an ultrasound because I don't know, it just wasn't going away in my mind. And so I went ahead and sent him for the ultrasound after the visit. And it actually turned out it was positive, which kind of caught me off guard. I'm glad that we got it done, but it does remind you that if it's on your mind, you probably should follow through on that. But then now we got to the part where I needed to figure out what to do with his medications. And like I said, I mean, he already takes a bunch of different things. He's a little bit resistant to needles. So he was really concerned up front when we said there was a clot and he had heard about having to be on needles all the time or what kind of medicine he might need. And so I was a little bit concerned about maybe what to pick that makes the most sense for him. And I was hoping maybe you had some thoughts about it.
Yeah, no, you didn't admit him to the hospital, did you?
I didn't.
Good. Okay. Yeah, no, I mean, typically for deep vein thrombosis, if we can manage them as outpatients, that's most desirable. So it sounds like you handled that well. Jeff, instituting therapy when we're going to be sending patients out of the hospital or out of the emergency department or home from the vascular lab, requires us to do things that aren't going to be too logistically difficult. What do you think about as the best pathway for a patient like this? Seems like very reliable patient when you're going to try to bypass the hospital.
Yeah, that's a really great question. And I think it's something that's changed for us here in the last decade. As we traditionally used warfarin as our main anticoagulant. But of course, when somebody had an acute DVT, we would often need to start them on low molecular weight heparin first. So they'd get those shots for maybe it's 5 or 10 days until their INR was therapeutic. But in the last, about 5 to 10 years, we now have these oral only strategies, which is really helpful. The direct oral anticoagulants. So I'm thinking in particular about apixaban, dabigatran, edoxaban, rivaroxaban. Those are the 4 available direct oral anticoagulants in the United States. They open up some more options. And in particular, some of them we can use just with oral agents. We don't even need to use any heparin beforehand. Others we kind of have to combine. So it's really changed the landscape and made it easier for us to treat people without being admitted to the hospital and without necessarily needing injections like low molecular weight heparin.
Margot,
it sounded like the DOACs were an option. Like that might be a thing that you could do. Do you know whether there were Black people in the studies though? Like, how do I know that would actually work for him?
Yeah, that's a really great question. And these, thankfully, were studies that were conducted across the world, including in the United States. And so they did have diverse patients involved. I would say that they probably didn't over-represent Black patients. That would obviously be nice. But the fact that these were really global studies, to me, gives some reassurance that the data from all those studies can be applied to really patients of multiple racial and ethnic backgrounds.
And I had a question for Margot. Margot, did the patient express to you like some reservations that he might have about certain types of therapies or preferences about how often he wants to take a medication or any financial constraints. It's just one of the nice things I think these days is that we spend more time talking about these issues with our patients. And I think for the most part, patients get to participate more in making decisions.
Well, it was pretty clear about not wanting to have to take off of work and being admitted to the hospital, which is part of the reason why we did the ultrasound sort of outpatient and just try to figure it out. And then when I called him back to give him the results, his first answer was, well, I'm not getting stuck with any more needles. And so, we struggled a little bit with getting those injections in for his diabetes. And so I don't know that he's a fan of needles. And like I said before, he'd had a friend who needed to be on medication before. And so he was just a little concerned about having to do an injection. And so his first questions were, do I really need to do that? Is that what's going to happen? And so we talked about the fact that there were some medications and that, for the one kind of medicine, you probably did need to do the needle first because you had to bridge it over. And that was sort of old school. That I had heard that there were these DOAC medicines that, we use for other things. And so I'm pretty comfortable using them for other things. But I thought that you could also use it for potentially for a clot and maybe even in the outpatient setting. And he was sort of interested, but then was a little concerned about, well, if it's new, how new is it? And is it going to be covered by my insurance? And am I going to have a big copay? And it didn't seem like that when I sort of did quick research. But before I went down that whole path, I just wanted to make sure it was even the safest thing to do for him or made sense. And it sounds like it might actually have been a good call to not have to send him to the hospital. And then now maybe we just need to juggle between the medicines to figure out which one might be the best for him.
Yeah, and I think that this is actually a great time to pose another question to our audience. And here it is: which of the following direct oral anticoagulants do not require parenteral anticoagulant bridging? So things like low molecular weight heparin or IV heparin. Here are the options: A, apixaban and edoxaban; B, apixaban and rivaroxaban; C, dabigatran and edoxaban; D, dabigatran and rivaroxaban; or E, you're just not sure. Let's give our audience a chance to think about this, and then we'll come up with the answer. And maybe I'm gonna, since I've got Jeff on the line, and Jeff spends a lot of time thinking about anticoagulation. Jeff, what's the right answer here?
Yeah, so the right answer here, which of these do not require parenteral anticoagulation, is going to be B. It's apixaban or rivaroxaban. And those are the ones where we can use this oral only strategy for treating patients with deep vein thrombosis or even pulmonary embolism.
Excellent, yeah. And I think that what Jeff's speaking about is the fact that our anticoagulation strategies are they're evolved. They're evolved because of the direct oral anticoagulants. For so long, we were used to bridging patients, giving them low molecular weight heparin or unfractionated heparin on the way to achieving that therapeutic INR with warfarin. And we don't have to do that anymore. Because of the direct oral anticoagulants, we can offer our patients some options. There's switching, where we would give still a low molecular weight heparin, but a shorter duration of it, and then transition over to an oral agent like dabigatran or edoxaban. And that helps patients to get quickly to stable oral anticoagulation, where warfarin sometimes is a period of trial and error before you get that INR. And then we also have the option of completely oral monotherapy. And as Jeff mentioned, we can give a higher dose of rivaroxaban or apixaban, and then transition to a maintenance dose. And that potentially really helps facilitate transitioning patients to home from the emergency department or from the vascular lab. And I think that might be of potential interest to our patient, Walter. Another thing that has sort of helped us is real world evidence. So we've got the randomized controlled trials, and we've already spent some time talking about the different populations in those studies. And as Jeff mentioned, they did represent different demographic populations, but maybe not as much as we would hope. And real world evidence sometimes includes broader populations. And so I think that real world evidence when it comes to anticoagulation has helped us to feel more comfortable at prescribing direct oral anticoagulants in different demographic populations, in some underrepresented minorities in the randomized controlled trials. And I think that in some ways that comfort has led to increased utilization. Jeff, has real world evidence helped to influence your practice? Does it give you a little bit more confidence with DOACs in some of the special populations?
Yeah, Greg, I think that's a great question. And it definitely has, right? And I would say it has helped me in two ways. The first is people have published on their experience in broad populations. So people with different indications, maybe different ages, as you mentioned, Margot, even different racial, ethnic groups. And so that's helped me feel reassured that this is useful. But even just my personal experience and looking at those of my colleagues, these direct oral anticoagulants are really now the drugs we reach for first. And the guidelines even suggest that that's really where we can go first to say, this is the best way to treat somebody with a DVT or, other indications. And so the majority of the time, I and my colleagues are really using these different direct oral anticoagulants. We still use warfarin because there are patients for whom that's best, but it's become the minority of cases. And so I've had some really good experience, and that's for me been really reassuring.
Jeff, tell me about this process of shared decision making. So you've got real world evidence, you've got the randomized control trial data, and then you have the patient in front of you. How do you bring that knowledge to the patient, and how do you get knowledge from the patient to know what their wants and needs are when it comes to treating them?
Yeah, I think that's an important point. And Margot, I love that you were sort of already thinking about that when you were talking about Walter. You mentioned that he said to you, I don't want to take a shot, right? And so hearing things that are important to him, what are his values, what are his preferences, I think can really help you make recommendations for him that will align with his values, align with sort of the things that are most important. When it comes to this decision, yeah, do I want a shot or do I not want a shot? That's obviously a big one. I also hear a lot of conversation around what will the cost be? These direct oral anticoagulants, depending on your insurance coverage, may be more expensive than somebody is able to afford. Well, we have another good option, but again, we have to weigh sort of the pros and cons. I also hear about things like, can I reliably take a medicine twice a day? Or do I really need to stick with a medicine that's only once a day so that I can be sure I'm taking it, right? And again, are those things that are really important? Is this something where I'm going to look back and say there's 20 or 30 years of evidence? Or can I say that, yeah, with 10 years of good clinical experience, I feel confident in that? So as I start to talk to patients, I usually bring up a few of those and hear from them what's most important so that we can come to that decision together. So I was really happy to hear that you had sort of started that process with Walter.
Excellent. So we do have one more audience question, and then we'll get back to Walter. Hopefully he's not waiting for us to get back to him. But speaking of Walter, should his anticoagulation be extended beyond 6 months? So we're going to treat Walter for the acute phase, but what about longer? And here are our options. A, yes, because his age and ongoing chronic risk factors. B, no, because he's at increased risk for bleeding. C, no, because the data doesn't currently support extended therapy. Or D, you're not sure. Go ahead and think about this, and we'll give you some time to come up with an answer, and then we'll see what the correct answer is. And the answer here is actually A. Yes, because of his age and ongoing chronic risk factors, especially that obesity. This is an important question, and it's going to be a question that we are going to explore further with Dr. Savoy when we see the patient in follow-up.
Hi, Greg. Hi, Jeff. Thank you guys so much for talking to me about my patient, Walter. You might remember it was like 6 months ago. I called you and then you guys were together. And so we talked about his DVT that he had. He and I had a really great conversation after I got off of the Zoom with you guys. And ultimately we decided to put him on a DOAC. And so he's been taking it faithfully for the last 6 months. He hasn't been having any other troubles. So no more clots in the past 6 months. But, Walter being Walter, the last visit that we had, he was like, do I really have to stay on this medication for the rest of my life? Because it's been 6 months. I haven't had any more clots. Things are great. And I sort of told him a little bit about what we had talked about the last time, but I figured I'd ask again. Maybe the evidence has changed or you guys had some other ideas about it.
Yeah, I think now's the time to think about the risk of recurrence. I think that we're in a state of flux right now in what we think about the different risk categories for recurrence. We used to divide patients up into provoked and unprovoked. I think we're now doing things with a little more nuance and considering risk factors like obesity that our patient Walter has. I think that the current data suggests that for patients with a DVT or PE that wasn't triggered by a specific event like surgery or a birth control pill, the risk of recurrence is quite high. And we do typically, as we spoke about last time, we do think about extending anticoagulation. And so I think Walter would be a good candidate for that. Essentially, we want to prevent recurrent DVT and PE. We don't know what form that's going to take. I mean, he had a DVT the last time. Is it going to be a massive or a high risk PE the next time? We just don't want to put Walter through that. And with the DOACs and with our current options, we can give the patient a 60 to 90% relative risk reduction from recurrence. And I think that's kind of what we want to do for Walter. Jeff.
Hey, Greg, I was going to build off of that. When I see my patients at this sort of 6-month mark and I have this conversation with them, Margot, one of the things I often explain to them is if we continue you on an anticoagulant like a DOAC, you're really reducing the chance of having another blood clot. And I try to make it accessible by saying, think about shopping with a coupon. And what I'm basically giving you is like a 70% off or an 80% off coupon, right? That's pretty good. And most patients sort of get that and they say, oh yeah, it's not taking all the risk away, but it's really doing a pretty good job at preventing that next blood clot. And so that's the way I try to make it accessible or understandable for them.
And Jeff, are there particular studies that you talk to your patients about, even you by name, when you think about extended duration anticoagulation?
Yeah, that's a great question. There've been a lot of studies in this space. Many of them were done back when warfarin was kind of the primary treatment. But, nowadays, especially for patients who are taking the direct oral anticoagulants, I'll often talk to them about, those as good options. And in particular, I'll talk about the Amplify extension study. This is one where one of those direct oral anticoagulants, apixaban, was actually tested against placebo. So some of the patients just stopped their blood thinner altogether. But those that kept going on apixaban, again, it was like an 80 or 81% reduction, relative risk reduction in having another clot. To me, that's huge. There was another really interesting study because some patients will say to me, well, doc, can I just take an aspirin? And Margot, I'm sure people ask you that as well. There was a cool study called the Einstein Choice Study where they used a different one of the direct oral anticoagulants. This time they used rivaroxaban, and they compared that to aspirin. And again, you see significant reductions. I think it was like 74 or 75% relative risk reduction in recurrent clot with actually really similar risks of bleeding. So I tell my patients, if you're able to tolerate the direct oral anticoagulant, if you're not having bleeding complications, you can really get the most bang from your buck by staying on one of these direct oral anticoagulants long term. When Greg, like you mentioned, they're in more of that moderate or high risk group for having another clot.
Jeff, do you think that the conversation for extended duration anticoagulation is a bit easier with the lower intensity regimen? So you mentioned two of my favorite studies, Amplify Extension and Einstein Choice. Both of those actually looked at lower intensity regimens, apixaban 2.5 milligrams twice daily in Amplify Extension, and rivaroxaban 10 milligrams in Einstein Choice. What do you think about that? Is that the next level for sort of anticoagulation and getting more patients to sort of think favorably about this?
Yeah, Greg, I think it is. And I find a lot of patients just like, they psychologically like the idea that they're not taking as much drug, right? There's something that feels good about cutting down the dose, even though we know from these studies that both the full treatment dose and this kind of half dose, they were pretty similarly effective. They both reduce the chance of getting a blood clot. So I actually feel really reassured by the ability to use them. Now, there are some times where I won't. If somebody is at really high risk for having another blood clot, maybe like a cancer patient, that's probably not a time where I'm going to cut down the dose. Or, some of my patients that are extremely obese, I'm talking, BMIs of 40, 50, things like that. I may not quite trust that lower dose, but honestly, for the majority of my patients with a DVT or PE, once we hit that 6-month mark, I'll often talk with them about the option of using that half dose strategy as my long-term or my secondary prevention to help prevent another clot from forming.
Marco, in your practice, since you spend a lot of time holistically looking at patients, do you go through that process of like bargaining with patients about lower doses? Like they may say, I don't want to be on anything. Now with these lower doses, you could say, well, how about we put you on a low intensity regimen? Is that a process that you go through frequently with your patients?
It is a conversation that we have often, particularly if you're allowed to go from 2 pills to 1 pill or even just a lower amount. They feel like they've done something that's progressing. So it's not just that, they've got a condition and the condition is the same forever. But in this case, they actually got to move back down so that they're doing the right thing and they're getting a bit of a reward in the process. And so I find that does come in handy. And I know for Walter, he's a numbers guy, right? He's an accountant. And so when I was sort of explaining to him the bang for the buck idea, I didn't have the coupon idea, but I'm going to totally steal that, Jeff. But I honestly just explaining to him the bang for the buck, like he was like, yeah, so ask them, but like if we really have to stay on it, we'll stay on it because I really don't want to have another clot. And the idea that the next one could be the big one is a big thing for people. But the everyday of having to take a medicine sort of weighs on people over time. So anything that you can do to give them a little bit of relief back is always a nice gift.
And I love that idea that you mentioned about progress. I think in a way that does show that they're progressing from needing a lot of anticoagulation to less. So that is a really cool thing for patients. Jeff, can you tell us a little bit about the guidelines? I know that you often talk about the ASH guidelines, but there are also ESC guidelines. Tell us about the way they've sort of changed the way we think about VTE. And, we're not really talking about provoked or unprovoked as much anymore.
Yeah, Greg, that's a great point. And I would say that both of those guidelines are actually pretty similar when we think about reasons that people may have developed their blood clot and what that means for the risk of another one. And so they group things into, people being at low risk for having another clot, more of that intermediate or moderate risk, and then the high risk group. And a lot of that has to do with, are there risk factors that were associated? And is that risk factor transient, something that'll go away, or is that a persistent risk factor? So, somebody who had a big surgery 2 weeks before their blood clot, gosh, that's a transient risk factor. As long as they don't have another surgery, they're probably at low risk of having another clot. That's probably not somebody who needs long-term or secondary prevention. On the opposite end of things, people with cancer or people with, really significant thrombophilias, I'm thinking like the antiphospholipid antibody syndrome. Those are people who have persistent, significant risk factors. They're at high risk for having another clot. They definitely are going to need ongoing prevention and anticoagulation. And then there's that group in the middle. Those are the intermediate groups. Maybe they have a persistent risk factor like obesity. Maybe there was no identifiable risk factor that we could really figure out. And those are the patients in whom I tend to sort of talk with them about, are they okay with continuing? Do they want to prevent the clot? Do they really need to get off medicines, or are they having bleeding concerns? Then maybe shorter courses are advisable. But even for that group, I find most of the time we tend to use ongoing or extended secondary prevention. So that tends to be my most common strategy. And that's really, I think, what both the European and the American guidelines recommend.
And for me, it almost seems like that makes more sense. It seems more natural to consider risk factors than to just sort of cut the population of VT down the middle as provoked or unprovoked. So in a way, I'm kind of relieved to know that we're moving in that direction. All right, well, now we're going to go through our SMART goals. Over the course of this discussion, we've talked about stratifying risk for VTE based on patient characteristics and comorbidities. We applied the results of anticoagulation, randomized controlled trials, and real-world evidence to the care of patients with VTE, or actually in this case to the care of Margot's patient. We assessed the utility of the direct oral anticoagulants in both the short and long-term management and secondary prevention of VTE. I'm really happy we were able to talk about engaging patients with or at risk for VTE and shared decision-making. I think that's just a more logical, more natural way of engaging our patients in their own care and educating them on their disease and their treatment. And I think it was a great opportunity for us to be able to consult back and forth with our colleagues in primary care and show how specialists and primary care physicians can talk about VTE management and rely on each other for an exchange of information. So I definitely want to thank Jeff for being my partner on this virtual consult from Margot. I don't think I could have elaborated on all the details without you, Jeff. And Margot, thank you so much for helping us and allowing us to participate in the care of your patient. I love when we're able to sort of go back and forth with you and talk about the best way to manage these patients. It's been really great to have your insights from the front lines as well.
Thank you. It's been my pleasure.
Excellent. Well, I want to thank the audience for participating with us. It's just been great to be able to share such an important topic like VTE with you. We hope that you found the information to be helpful and applicable to patient care in your own personal practice. Just a little bit of a note, you can visit the CME Outfitters Cardiology Hub for free resources for healthcare providers and patients on VTE and other cardiology topics. You can receive CME and CE credit, and there is a way to do that through the website. Want to thank you again, and definitely don't miss the second VTE briefcase activity in this series entitled Addressing Disparities in Care, Assessing Patient Characteristics when Determining Next Steps for Anticoagulant Treatment Selection. Thanks again, everybody.